Thank you, sir, Murita sir, for your valuable uh, suggestions of creating this beautiful masterclass for different subjects of assessments of the D assessments. Now, when we talk about the 3D mitral valve assessments, it has been proved that it has been validated for defining the extent and locations of the pathology. It determines the mechanisms of the severity of the valvular dysfunctions. And it also important that whatever we see on echo, it has to be communicated properly. So communicating results of the interventions and pre-interventions is very important. Now, if you say the anatomy, we all know the anatomy that it constitutes of the two valve leaflets. One is anterior mitral leaflet, second is posterior mitral leaflet. Now, the AML is occupying the 1/3 of the annular space, but it occupies the 2/3 of the mitral valve orifice opening. The PML is very important, though we always consider AML, but PML is very important because it occupies the 2/3 portion of the annulus and it governs the size and direction of the annulus. And there are some natural indentations that is called the natural scallops, which forms the posterior mitral leaflet into the 3 segments. Now, when we talk about the mitral valve, we should never talk about the only mitral valve. We should always talk about the complete mitral valve apparatus. And that it is mitral valve, annulus, leaflets, cords, papillary muscles, left ventricle per se is also a very important aspect to it. Every left ventricular wall, because it is all interchangeable. So very important to see that the mitral valve, annulus, mitral valve itself is a part of left ventricle, not left atrium. And the annulus also plays a very important role, which is we can say that it is a saddle-shaped mitral valve. So you have the two upper ends, and then to the lateral surface, the anterolateral and posteromedials are down as compared to the anterior and mitral leaflets. Now, the Carpentier has given nomenclature. So whenever we talk about the mitral valve, we can never forget the name Carpentier because he has given the nomenclature. There are some other nomenclature also, which divides the posterior mitral annulus from the left side of the anterolateral to the right side of the posteromedial into the 3 scallops, that is the P1, P2, P3. So this P1, P2, P3 is named after the natural indentations divides the PML into the 3 segments P1, P2, P3, and corresponding those segments to the anterior mitral leaflet is called A1, A2, and A3. So whenever we talk with the surgeons or interventional person, we should always talk in the language of the A1, A2, A3, and P1, P2, P3, and that is very important. So because we can say exactly where the pathology lies. In 2D assessments, we know there are the 7 important the images we look for it. One is 5 chambers view, midesophageal 5 chambers view, where there are the 5 important views of the midesophageal segments. And these these views are mostly in the long axis, and they are you can see in the left side top, it is purely we can see the A1, P1. On the right side, we can see the A2, P2 because it is cutting more posteriorly. On the commissural view, the left more is a P3 and right side is a P1. So it is many of the time it is confusing for the surgeons to understand when we show them the 2D images, but it is very important that we ourselves understand this very properly. But very important before jumping into 3D that we should be able to identify the scallops on 2D images as well. So it is not that you straight away jump to the 3D, and remember that unless and until you have the best 2D images, you cannot obtain the best 3D images. So very important that you go through the 2D images first and understand this segmentization. So transgastric, there are 2 important views. We'll just see one by one. Now, the mitral valve is usually seen in the 3 important way of seeing is, or we can say that the software applications that is called real-time or live 3D images, which is a multiple pyramidal data set per second in a single heartbeat. So it is a live 3D, means whatever you are seeing on the heart, it is seen in the machine. So it is a multiple pyramidal data set. Here, why we call the pyramidal data set? Because when we take an images of the 2D images, it is just a slicing of images. It is just one slice, like we are cutting the vegetable in one slice and we are seeing from the top. It is like what we are seeing in the 2D. But in 3D, there are the multiple these 2D acquisitions and stitched together to format the 3D images. So they are called the pyramidal data sets. So this pyramidal data set acquire the complete images of the area of interest. And if it is taken in the live images, so every second in the single heartbeat, it is called the live 3D. And this is how you can see the live 3D. Just after imaging, you get 2D images, press the 3D, and you can see the very nice live 3D data set. So live 3D data set is also very important. And then you can adjust the zoom, you can adjust 2D gain settings, and then you can make it much clearer. So this is called the live 3D, and live 3D using the matrix and transcription, and it makes it now. I'm getting some noise from the back. I don't know. So like if you compare it, see here we are just judging by looking at the 2D that okay, when you see the aorta, you are cutting in the anterior segments. But here you can see that anterior mitral leaflet is clearly seen that when aorta is seen, we are seeing the anterior aspect. If you go deep, we are going much into the posterior aspect, but this is the anterior aspect. This is of AML, and this is a PML. So we are cutting from the AML PML from the A1 P1, and that clearly seen from the live 3D. Or we can say that if you are going more posteriorly, where you don't see the aorta, but now we are cutting these segments from the nearly the half. You can see the segments from the middle part of the AML, where aorta is not seen. We can say to P2 because now aorta is not seen, and that we can clearly see in the live 3D of the mitral valve apparatus. You can see here no aorta is seen, but you can see that A2 P2 part because now the part AML and PML is cutting in the midpoint. Now, this is what we call it a bicameral view. This is the bicameral view. Why it is called the bicameral view? Because we know that you can see that the AML, when you are cutting exactly from the middle of the two commissures, this is the anterior commissure, this is the posterior commissure. You know when it is anterior wall and LA appendage is seen, this is more of the anterior part. When you are cutting from the anterior part, you are cutting to the commissures of the mitral wall. And this sandwiching leaflet is A2. And if we are not sure, we can see that why it is A2, you are cutting from here. You can see that this part is seen bulging up and down. In between some segments, this is whole posterior mitral leaflet. So this posterior mitral leaflet is just surrounded by the anterior mitral leaflet. So when you see the commissures, it is not that the two points of the AML, PML meet together, but PML in fact extends both commissures beyond the AML, because as I said, it occupies the 2/3 segments of the annulus. So when we are cutting commissures, we always see some part of the PML, that is P1, this is anterior, and P3 on the posterior. So this is how we can see the advantage of the live 3D. Now, when we see, this is the only view where we can see that complete anterior mitral leaflet. Here you can see the LA appendage, this is anterior wall, you can see the entire anterior mitral leaflet. So this is A3, A2, and A1 segments. Now, when you see the appendage, you can see the entire, and this is entire anterior mitral leaflet. And some part of the P3 segment is also clearly seen here. So when you see the LA appendage and what you see the anterior mitral leaflet, it is the entire mitral leaflet that can be clearly seen here. So LA appendage usually occupies complete A1, A2, and A3 segments entirely in the view. And so why I'm showing this, because when we see in the 2D images, we just judge and we sometimes mark that, okay, the LA appendage is the entire mitral leaflet. But this is the reason, and that can be clearly seen, and you can segmentize in the live 3D data set as well. Now, this is again an important view. We all know this important view that you can see that this is the mid-disciplinary long axis. It is just against what we are seeing, the 4-chamber view, where the anterior mitral leaflet was here, posterior mitral leaflet is here. Now we are cutting exactly at the midpoint. So when we see this mid-disciplinary long axis, what we see is A2, P2 segments, and that is clearly seen here, that you can see this is A2 and P2 segments. And this is the best way, like, so 3D images, like you can see here, the cut section. So why I'm showing and emphasizing this all in detail, because when you see the live segments, they just we don't extrapolate our image segmentization from the 2D, but we can clearly identify which segments we are cutting across. Now, this is a transgastric view, and these views are very important. As I said, when we talk about the mitral valve, we cannot say about the segment. We have to see the submitral apparatus and the cord. And this is a very best view to see the. This is the best view to see the cord, and you can see here the cords are clearly seen here. So you can see the this is an anterior, as usually on the screen. This is always anterior in the bottom of the screen. You can see this is anterior mitral leaflet. This is a cord, and this is anterior papillary muscle cord, and this is anterior wall. But now, when we want to see it from the 3D, and this is a transgastric view. Now, this transgastric view, whether we are seeing from the LA or LV, so we have the proof to it. Like you can see here, we are seeing from the apex, and you can see that both leaflets are very nicely clearly seen. Then here also you can see very nice submitral apparatus. We can clearly see two different papillary muscles, two different cords, and this papillary muscles, cords, and these are the leaflet. This is an appendage, and you can see here from the apex. And if you put a color, you can exactly identify. Like this is the patient. This is the patients when you have the color jet here, which shows that the regurgitation is from the middle and posterior segment. So this is how live 3D image is also very important. These are called the lateral planes, but these planes are non-conventional plane as per the guidelines, but these planes are also important to see that. So second important way is to see the zoom mode, and this mode is very friendly mode for friendly methods for the surgeons, where we just see the end surgical view, that is called end face view, where we just select the data of interest, and we can see this view is like the surgeon sees while opening the left atrium. So this view is giving the optimal resolutions of the lateral of the temporal and spatial resolution. Now we always know that in 3D echo data sets, it is always a trade between the spatial and temporal resolution. So when we want a best spatial resolution, we have to compromise some extent of the temporal resolution. So here we have the good images and optimum both spatial and the temporal resolutions. But now when we say that the 3D guidelines, how to view the mitral valve apparatus. So when we see the zoom method, as I shown in the last, the zoom method, that view, area of interest, we just select on the mitral valve and press the zoom. And in that, it gives data where you have the normally in the this is in the two views. This is what we can see. It is a 4-chamber view. This is 4-chamber view. This is a long axis view. We just select the area of interest and zoomed it, and then what we get the mitral valve annulus like this. So we have AML here. We have the PML here, but then we have to have the rotation. So this whenever we see the aorta, always remember when we see the aorta should be always at the 12 o'clock position. So here you can see the aorta. So this is the anterior mitral leaflet, and LA appendage is always to the left of the aorta, and that is at the 9 o'clock position. So this is the way how you should adjust. First, you select the area of interest, the pyramidal data set of area of interest, and then make a zoom button. And in zoom button, we see the aorta like here, AML here, and PML here. We just rotate in the anti-clockwise to make it anterior mitral leaflet to the top, 12 o'clock positions, where aorta is also at the 12 o'clock positions. LA appendage comes here. So we can see that this is the anterior mitral leaflet and this is the posterior mitral leaflet. Very important thing is that always remember that it is not that it should be in the LA aspect, even though the LV aspect it is the same. So here you can see the 3D zoom, and once the 3D zoom, we have to rotate it the 90 degree to see this AML, and this is the aorta, and this is the recommendations of the AAC SE guidelines where you should see the aorta. So this is the zoom mode where you can see that the beauty, you can see that AML and PML here. The beauty of 3D is you can see this both images at the same time. Like you can see that from the LA view and LV view. And this LA view and LV view is very important. Like we cannot just ignore it. I can see here. So again, like this is from the LA view, aorta, AML, PML. this is anteromedial, and this is posterior mitral. This is lateral aspects, and this is from the left ventricle view. Whenever we see the view from the left atrium, we always see the aorta at the top. That is very important. Then you just see that AML is, you can see left side. When we start writing on the paper, from left to right we start. So we start from the lateral to medial. That way, this is aorta. We can see this is aortic wall. This is anterior mitral leaflet. This is from posterior mitral leaflet, and this is the LA view. This is a lateral aspect, and this lateral aspect we always have the appendage. Appendage is always anterolateral. So this is the lateral part, and from segmentation starts from the left to right. That is from the anterolateral commissure to posterior medial commissure. That's what you can see here. This is AML, this is PML, and this is anterolateral. You can see this part of the LA appendage, and this is the medial part, and aorta is here. This is from the LA view. Now, when we see from the left ventricle view, again, you have to see that the aorta should be at the 12 o'clock position. So the AML is here, PML is here. Of course, because we are seeing from the apex, the lateral and medial they switch each other. So medial becomes here and lateral becomes here. Now the question is, why we need to see from the apex? So that I'll show you later. This mitral wall, now this is how you can see that whatever the out of mid-esophageal 5 views, whichever the view is best to you, that should be selected. Sometimes 4 chamber may not be seen very well. You can select the mid-esophageal long axis view, and then you can go to so we can select any 0 to 120 degree mid-esophageal views, and with proper selection of the pyramidal data sets, where it is important that you take some part of the aorta as well. So when you take aorta, if you take the area of interest up to the level of the annulus, and if you miss the aorta, you cannot exactly keep the aorta at 12 o'clock position. So area of interest should be selected from the entire mitral leaflet and some part of the aorta to give a better understanding. So this is very important. And then not unnecessarily take an entire left ventricle or a left atria, but you can select some area of interest. This is the mitral apparatus. So any views from the 0 to 120 degree, you can select it without any problem. And what you can see is, so after that, you can see that whatever the images you are seeing is first from the LA view. That is very important. Second thing is, once from the LA view, aorta should be at 12 o'clock position. So automatically appendage comes at the lateral aspect, from where you can start the segmentation from the A1, A2, A3, and P1, P2, P3. So now, again, I say the beauty of the 3D is you can see the both segments. Now, if you see from the LA to aorta, so here you can see that what we selected here, the area of these are the two different orthogonal planes. So when we select the 3D zoom, you will get the two orthogonal planes simultaneously at the 3 different angles, probably the 90 angles. So here we have selected the mid-esophageal long axis view with the 5-chamber view. Why? Sorry, this is mid-esophageal 5-chamber view. Why we have selected this? Because we can acquire some part of the aorta also, and aorta is very important to locate the anterior mitral leaflet. So automatically the other orthogonal view comes at the 2-chamber views or mid-esophageal view, long axis view. And then once we just press this button, here you can see that the whole AML and whole PML is seen A1, A2, A3 from the LA appendage view, P1, P2, P3, and the aorta is seen. Here you can see that from the bottom we are seeing that. So this is again an aorta. And here when you see that it comes A1, A2, A3, P1, P2, P3, because medial part goes here and the lateral part comes here. So it is just switching of the segmentation, but the AML remains the same position, PML remains the same position, and aorta remains the same position. That is what it is advised. Now, why we are looking for this leaflets from the posterior aspect? The reason behind it is, that you can be very much clear of certain aspects, like PML is clearly and AML is clearly very seen now. Sometimes the AML protruding into the aorta is clearly seen in the case of the SAM if you just see from the apex. And this view is fantastic. You can see here the apex. You can see this is the transthoracic view from the fourth chamber, and we have selected only some part of the mitral valve annulus. And so you can see this is an aorta. So we can see the an aorta relations to the AML, and we just cropped much more than we can see it from the anterior aspects as well. So viewing from the apex is also important. Sometimes the posterior mitral leaflet and the papillary muscles and cords are very nicely seen from the apex. So it is also important you see the simultaneously the both images. Now here you can see that this is the most zoom mode. You can see that this is AML and this part is in the aorta. So even you can see the nice correlations between the AML to the aorta. So very important that you always see from the LA and LV. Now, suddenly we should not jump into our diagnosis in intraoperative period when we talk about the quantifications and hemodynamics, though this talk is about the assessment, so we will not go for the quantifications, but we'll see some important structures. So the important of the 3D in perioperative period, there will not be impact of the hemodynamics performance, there will not be impact of the cardiac condition, because once we record the end-phase view and then we can adjust the speed and very gradually we can see which part is there. Sometimes when you have the patient coming from the mitral valve rupture, the cord rupture, that time patient is always in the hyperdynamic format, severe tachycardia. We don't know whether it is a vegetation or whether it is a cord rupture. So in this case, if you see the end-phase view and reduce the speed, you can exactly know that whether the cord is flowing into the direction of the AML or there is a vegetation on the atriomitral leaflet. So this is very important. And once we see communicating with the surgeons in the same end-phase view is very important. Now, when we want to report a TE for the mitral valve in 3D, we should, I will not touch again the MR and MS in depth, but we should always tell the exactly specific location of the prolapsing or failed segments. We should see that whether the segments is tethering or restricted. Look for the perforations, calcifications, excessive length, thickened appearance, mobility, calcifications, every aspect of the thing which is required to explain the leaflet. Because when surgeons are planning for the repair or replacement, these things are very important, like whether they are the tethered leaflet, there are restricted leaflets, they are the pathology, whether it's a Barlow's or it is a fibroelastic disease, the deficiency disease in a degenerative valve, whether the aortomitral calcification is there or not. I'll just show you some images. So we have to explain exactly, and that is the area where the 3D is important playing role. As I said, annulus, the saddle shapes can clearly seen. Here you can see this is aorta and some part of aortomitral calcification if it is there. Now we can rotate the images to 90 degrees and we can see entire aorta, aortic valve and aortomitral curtain. This is the aortomitral curtain and you can see that whether it is a calcification or not. And you can see here even in the annulus, like in the HOCM, you have the reductions of the aortomitral angle, and you can see this is a very acute aortomitral angle, and you can see the both leaflet is pushing into the septal hypertrophy. So this view is again important. Now, etiopathology of MR is again important. Like in operation theaters, we always say that which segment is involved. But here you can see that we just have a judgment that okay, it is A2 or A3 or P2 or P3 while looking at the various segments. But when we see this into the 3D aspects, we can exactly locate whether it is a P2, P3 flail, and that if you put a color and we can exactly inform to the surgeon, and that you can see surprisingly that it is correlating well to the intraoperative findings. Now, before jumping, we have to understand to see the pathology of the Carpenter functional classification. We should know which is usually required 2D, which does not require 3D. But in some aspects, we need a 3D, like patient had a significant regurgitation, but you can see this is a perforation in the PML. Once we see the perforation in the PML, we can say that, yeah, it is a PML perforation, and the rest of the leaflet looks okay. So this is the type 1. So rest in vegetations also, I will show this image in 3D, that you can see which cords are and how the leaflets are, whether it is a degenerative disease, a type 2, but whether it is a fibroelastic or whether it is Barlow's disease, myxomatous disease, that has to be clear. Now in rheumatoid, this again, a very different pathology, we can see that, and it's difficult to find out which pathology is that. But here again in 3D, we can see that, okay, this is type 3A because there are a lot of calcification, fibrosis, and restriction of the leaflets. And in the ischemic MR, so all these types of the Carpenter function classifications can be identified very well into the 3D aspect. Now, in degenerative disease, we want to classify the degenerative disease. We have to see the leaflet size, annulus, coaptation length, CSAP distance, size of the LV very well. And this is how you should measure the CSAP distance. And this is again very well seen in the 3D. I will show one by one. Now, in degenerative, we know there are two kinds of degenerative valves. So when we see on 3D images like this, here you can see the P2 flail. But we don't know what is a degenerative process, what is the process of the pathology. Here you can see that this is thickened leaflets and this part is flail. But when you put a 3D, you can see this is a bileaflet prolapse and there's a multiple scallops. All the 6 scallops of the mitral segment is involved. And we can see that when both leaflets are involved, both leaflets are flail or both leaflets are prolapsing, we can say that this could be the myxomatous Barlow's varieties of the mitral leaflet. That was difficult to see by here. But when you see, again, this is thickened leaflets, you have the cord ruptures, but we don't know exactly what part is we are looking for. So in 3D aspect, we can see that, okay, only P2 is a flail. You can see that 2 cords of the P2 is ruptured. Now we can see that when you have the only one segment involved, small annulus, and you have the only and you have a cord ruptures, you have usually a fibroelastic deficiency. That is a degenerative fibroelastic deficiency, because this you get beyond the 50, 60 years of age, less thickness compared to the myxomatous Barlow's, and there are usually cord ruptures because they are the thinned out tissues, and you have only 1 or 2 segments are involved unless there is a long standing. And the left ventricle cavity is very narrow. Like here, you can see the LV cavity is not very enlarged as compared to the Barlow's. So we can straight away see that, okay, one segment is involved. This is fine. This is the fibroelastic disease, not the Barlow's disease. But many of the times you have the form force varieties of the Barlow's where you can see the left ventricle is not big, but you can see this, both leaflets are involved. So they are not having the specific characteristic of the Barlow's disease because left ventricle cavity is small. So this because of the extension of the Barlow disease when it is become the fibrosed leaflets, and you can see that still you can see that both leaflets are prolapsed. This is from the apical segment, and you can you can see the surgeons can repair very well such kind of the patients because here you have the left ventricle cavities, annulus is small, you have the adequate tissues, so the repair is possible. So we can have the better results if you can show them very well. Now, even against the Barlow's, European publication was very wonderfully said that when you have the Barlow's and you have the posterior mitral, posterior commissure is involved, like in this case, you can see that posterior commissure is involved, which is not clearly seen here. You can see the posterior commissure involved, and in this, when you have the posterior commissure involved and more than 3 scallops are involved into the both leaflets, we can see that, okay, this is a repairable valve still because posterior commissures are involved, and we can always ask request surgeon that you can attempt for the repair because the anterior mitral leaflet segment is still preserved. Here you can see that the anterior mitral segment is still preserved, but posterior commissure is bad. So this is still repairable, feasible, but of course it is a little complicated. But if you see such images where you can have the anterior commissure involved in the Barlow's disease, you can see surgeon that is going to be a nightmare because the anterior commissures are involved. That means a major part of the AML and PML is involved, and this is a difficult one and not possible. You have the failure rate of nearly 80% of the cases on Barlow's. So this is not possible with the with the surgeons actually to see in the 2D view. Now, if you just do the extensions of the mitral valve quantifications, that is again, I won't go much into detail because it itself is a big subject. You can see here the anterior commissure is involved, clearly seen, and you can image the mitral valve quantifications about the annulus quantifications, the leaflet quantifications by the advanced software or mitral valve quantification. This is a GE software, and you can see that we can configure and tell surgeon that, okay, this is anterior mitral commissure part is involved into the Barlow's disease. And you can see there's multiple scallops are involved here. So this valve is not the base valve is involved. So it is not only to differentiate the Barlow's to fibroelastic, but it is also differentiate to repairability to the non-repairability. Now here I showed you that, okay, you can see the surgeon, like, okay, this is looking like left ventricle is okay. This is only one segment involved. The cord is ruptured, so this is most likely the fibroelastic disease. And fibroelastic disease is the one which can be nicely repaired because the LV geometry is preserved because they are the acute patient, acute stages. But of course, these patients usually should be subjected from the angiogram before subjecting because they are usually coming in the little age group. Now here also, sometimes in a fibroelastic, we have more than one segments involved, that is A2, A3 segments involved, and that you can see that mainly the A3. This is I'm showing from the posterior aspect, where you can see this part of the A3 segments. Here, this A3 segments, like I'm seeing from the apex. So this is medial, this is lateral, this is anterolateral, this is posteromedial, and you can see this A1, A2, and A3, P1, P2, and P3 from the apex. And this is what you can see the aorta here, posterior leaflet here. So naturally, this becomes the A3 segment, and this A3 is flail. You can see that the cord of A3 is ruptured. So even a posterior mitral leaflet and anterior mitral leaflets both can be seen very clearly from the apex. Now, after repair of these patients in the perioperative period, you can see this SAM part. You can see in the 3D very nicely, clearly the SAM in just after time of coming of bypass. You can see very well happening the SAM, and even the SAM, even after repair, you can see the regurgitations very clearly, and this regurgitation is coincidentally with the SAM formation. So in the post repair also in the 3D, we can exactly know how the SAM is touching. Like you can see the septal hypertrophy is not there, but there is definitely the coaptations of the leaflet which is touching to the septum. So the post-operative also is very important. You can use the mitral in the HOCM also. Like here, you can see that this is very nice view. You can see that this is the aorta, and anterior mitral leaflet is just pushing back into the annulus when it is valve is opening. But in HOCM, we can see that when we talk about the HOCM, you can see that the aorta part is totally closed at the time of systole. This is aorta, which is totally closed at the time of systole, and AML is pushing it. So the apex view is very important for the anterior mitral leaflet, all the segments, as well as there is dynamicity to the LVOT segment. So this should be always seen at the same time. Now, ischemic MR. Now we know that in ischemic MR, always the leaflets are normal, but usually what we see the mitral valve is normal, but the left ventricle geometry is disturbed, and we have the four different ways to see it. But here, when we look at it, here, you can see that in a short axis view, transgressive short axis view, you can see the regurgitation is from the A2, A3, and P2, P3, and that is because of the posterolateral displacement of the left ventricle, and that is a tether PML and AML. So here in the clearly end-phase view of surgical, you can see very nice mitral valve where leaflets are looking okay, and you can see this is the regurgitation in spite of leaflets are normal, and we can say that yes, this is the ischemic MR. And what we do in our routine practice that we do always strain and speckle intraoperatively, and you can see the infralateral segment, the posterior segment is involved, and that is clearly seen here. So when you have the infralateral segment, like this segment is involved, and we can always see with the strain and speckles in perioperative period to tell the surgeons that, okay, this part is damaged, and if they have the viability of this particular area, then we can say that, okay, you can try. The thickness of the myocardium is preserved, annulus is not big, and the viable and graftable coronaries, we can see that, okay, this myocardial thickness is preserved. So just see, you can see there is no scar or fibrosis. You can see that, okay, you can put a graft and see it. But it can differentiate, this advanced software can also tell us the guidance of the wall motion anomalies. Now, in submental apparatus, as you can see, this is a deep transgastric view, where you can see that this is transgastric view. You can see that the both papillary muscles can be seen. And this is an important view, mostly in the rheumatic pathologies, where you want to see the submental apparatus and length of the cord and the papillary muscles, the crowding, everything can be clearly seen in this view, as well as in degenerative valve disease, whether it is a cord rupture or patient has vegetation. So can be differentiated well. Now, we had one case in a post-repair where you can see in all the repair segments, it was looking nice. But when in another case, when we just, another case, you can see that even after the repair, AML, you can see this AML is touching, this is entire, you can see this is the entire AML, you can see here. So you can see that AML is touching here to the PML and annuloplasty ring is seen, and there is a typical regurgitation from the A3, P3 segments where AML is bulging out. Here you can see that AML is bulging out from the ring. So we are always discuss with the surgeon that, okay, this is A3 is not coapting well with the P3, or it is coming out from the ring. So surgeon goes inside the operate, again go back to the open heart, and we just put a commissural alveoli to the A3, P3 segment, and we can see very nice, clearly smiling mitral valve annuloplasty ring assessment. So what I'm saying, it is very important to see the mitral valve in end-phase view, the lateral planes in live 3D as well as the zoom. So we can exactly tell surgeon. So this is not a beauty to keep it with us. It is a beauty to explain it with the surgeon. The surgeon becomes totally dependent upon our images. Now in rupanic pathology, this is see that all the valves are very bad. You can see that the mitral valve calcification, the aortic valve calcification. There's a lot of aortomitral curtain, which is calcification. And we can see that these part of the mitral valve, by any way, it is not only the difficult to repair, but it is not possible to repair. But when we do the mitral valve replacement, the chances of having the touching the aortic valve as well as some cords or conduction blockage is also possible. So this kind of a very bad mitral leaflet is subjectable. Now, for the grading of the stenosis, whether you can do the open mitral valvotomy or not. Sometimes we have a patient with a moderate AR to severe AR for subjecting them for the AV replacement. But sometimes we look at the, okay, mitral valve is not looking very bad, no fibrosis, calcifications, commissures are not bad. So we can see that whether OMC is possible or not in this case while we are doing a replacement. So what we see is, look at the commissure and divide the commissure in the two planes. One is a outer plane and one is the inner plane in the both the sides. Like here, you can see that the commissure is here, but there is a calcification extended beyond the commissure. So this is a plane 1, this is a plane 2. Here you can see that posterior mitral commissure is spare, and this is not the base valve for the BMV. What will happen? They open the balloon here, and then they give balloon with such a high pressures. These calcifications doesn't allow balloon to inflate, but the pressure will go to the leaflet and you get a leaflet tear. So here, what you must need to see that look at the commissures. If both the commissure is fine, then we can see that there is 0, numbers. When you have the one commissure is okay and another commissure, both are calcific beyond the level of commissure, and this is number 2, 1 plus 1 is equal to 2. But here you have the 0 degree, means one commissure, posterior commissure is free and the anterior commissure is totally calcific. If it is 2 by 4, still you can attempt for the mitral valve opening. Or there is a 1 number here, 1 number here, still you can try for the mitral valve opening. But when there is both side commissures are fused, then you have the 3 or 4 numbers, like 1 plus 1 is equal to 2 on the anterior and 1 is plus 1 is equal to 2 on the posterior. If you have the 3 out of 4 or 4 out of 4, then you should not go for the patient with the commissurotomy, because then you are cutting the commissures to the level of annulus, and these two leaflets will not coapt very well because it's a fibrous, thick calcification structure. So unless you have to again to go take sutures to close it up back. So look at the commissures. If commissures calcification is extended beyond the level of the annulus, beyond the level of commissures, then you grade 1, and the grade calcification of a commissure grade 1. So the 1 plus 1 is equal to 2. Again, in the other side of posterior commissure, if a commissure is only involved, grade 1, and if it is involved beyond the commissure, it is grade 2. So total is 4. If you have the 3 by 4 or 4 by 4, this is the not-based valve for the commissurotomy. Like here, you can see that it is an extension beyond the just commissure. Here you can see that this is this extension of beyond the commissure on this side. So these numbers are 2, but these numbers are 0. So you can do only the you can request surgeons to do only the commissurotomy of the one side. So this can help also to understand the surgeons. Now, whether OMV, while doing the performance of the AVR, or as I said, you want to repair the rheumatic mitral valve. So whether this is possible or not, and this is a very nice, data we have, that if you have the pliable non-calcific valve, like seen here, the pliable non-calcific valve, and anterior mitral leaflet is clearly seen, and the thin cord, which can be seen here in the 2D view, the thin cord which has got from the head of the papillary muscles to the level of the tip of the primary cords. So we know that the tip of the leaflets are the primary cords, and body of the leaflets, when they are attached, it is called the secondary cord, and when they are touching to the posterior mitral annulus base, it is called the tertiary cord. So when the length of the primary cord is more than 10 or 10 millimeters, and as far as AML is clearly, and AML is spared, we can say, okay, you can do the commissurotomy. But in certain case, when the AML is also involved, PML is also involved, so we can say that, okay, this is not the valve to be do the OMV. So the rule of thumb is AML has to be spared. There should be non-calcific anterior mitral leaflet. There should be the pliable and non-calcific and non-fibrous, and that can be clearly seen with the 3D images and lateral plane as well as zoom plane. But it is difficult to see into the 2D images, and you can measure the cord length very well. So this is also helpful in rheumatic pathologies, that okay, group 1 or group 2, that even though cords are thin but AML is spared, we can do the repair. But if the AML is affected and fibrous, here you can see this is a fibrous calcific AML, then these are not the best valve to be seen. Even it can be differentiated whether there is a vegetations or the cord ruptures. Here you can see that very clearly seen the vegetations. What happens that vegetation doesn't go into the left ventricle and left atrium unless it is involving the submental apparatus also. Usually when there is a cord ruptures, it goes to it is attached to the below, it is attached to the ventricle surface, and it goes in the direction of the leaflet. But here you can see that in the vegetation, it is just going up and down. It's not going to the left ventricle, and usually it is attached to the low pressure area, which is left atrium in this case. So we can differentiate that, okay, it is attached to the left atrial part of the anterior mitral leaflets. It is not hanging in the left ventricle and going up to the left atrium. So it is vegetation, not the cord. So this can be even differentiated. So sometimes you get a patient with a hyperdynamic ventricle tachycardia of 120, and we don't know whether it is a mitral regurgitation because of the cord ruptures or vegetation. So we can do the lateral planes as well as zoom planes, and you can see that, and you can reduce the speed to differentiate, yeah, it is a vegetation or it is a mitral valve cord rupture. Even you can differentiate the leaflet between the scallop. Now, if you have the ischemic MR, annulus usually dilated, the posterior mitral leaflet scallop is dilated. So sometimes we don't know whether just annuloplasty will suffices. If the scallop is expanded because of dilators of annulus, then we can say, okay, only annuloplasty will serve the purpose. But if there is a full-fledged the cleft is there, then you can discuss with the surgeon that these parts should be repaired by putting one stage between the P2. So you can even differentiate the scallop is dilated in a dilated annulus, or it is a scallop. By definition, when it is extending to the level of annulus, it is a cleft. If it is not extending to the annulus, it is a scallop. So this is, you can differentiate very well. So now the severity of MS, you can, in the 3D quantification in perioperative period, always misleading, but here you can see this is beyond doubt, it is a severe MS. But here you can see this aortomitral continuity. This is a very nice view for seeing the aortomitral continuity, and you can see that it is a very calcific mitral leaflet, fibrous leaflet. So surgeons may be struggling in doing the mitral valve replacement. So aortomitral constraint can also be seen very well in the 3D. You can see this is from the apex part. This is hardly moving structures, and these are the not only the best part of the repair, but this is worse for the replacement as well. Now, I have had an opportunity to work with Dr. Sampath Kumar, who did delaminations in the workshops, that he does very well delaminations, but I had a very nice discussion with him that on 3D echocardiography, there has to be some pliability of the leaflets for the delamination. This kind of the valve is not the worst valve for the delamination. So pliability should be there, or there has to be not a patchy calcifications. Otherwise, they are not this is not the best valve for the delaminations, also for the repair. Now, apart from that, when you see the mitral valve, you have to see the L appendage, the clot in the L appendage also should be seen very clearly. You don't see just leaflet apparatus and get away with it. You have to see the complete L appendage. You have to see the other valves as well. Because rheumatic and degenerative valves, both valves has got tendency to affect the other valves as well. So when you see the mitral valve, do not spare the other valve as well. Because this valve, again, you should see the pathologies. So this is how you can involve the mitral valve. You can see the mitral valve in depth, and sorry for the technical glitch, and if it is too much extended of the time, and I regret for that. Thank you very much.
Thank you, Naman, for that excellent review of 3D, use of 3D in mitral valve assessment, especially when we do the repairs. We already overshot the time by about 40 minutes, I think, more than that. Anyway,
yeah, 30-40 minutes paired in the
okay. What is done is done. We can't redo it. So can we, if there are any two quick questions or comments, we will take it and then close it. Anybody wants to say anything on this matter?
Sir, there is a question from Sanjeevani ma'am, sir.
Yeah. What is that?
How to know about
pliability of AML?
Yes, sir.
Hello.
Naman, can you answer that one?
Yes.
Pliability of AML?
Yeah, the pliability of AML, you know, there is a risk score, but I won't go into the risk score detail. So when that can be seen even on the 2D as well. So when there is a coaptation of the AML and PML, some part of the body should touch the mitral valve annulus or beyond the annulus. So usually when there is a rheumatic involvement is there, usually the primary cords are involved first and then the secondary cords involved, because the progression of the calcification of a rheumatic patient starts from the edges to the base. So primary cords are thickened and retracted, but the secondary cords are still spared. So what will happen when there is a coaptation? So the tip of the leaflets may remain below the left and below the annulus, but some part of the body which goes above the level of annulus. So there is a doming of the mitral leaflet, what we can see in the simplified way. So when you see the doming of the AML, we can see that, okay, AML is pliable. So what will happen in the diastolic phase, it will become the hockey-like appearance. In the systolic phase, it will be appearance like the concavity into the left ventricle. That we can say that it is a pliable AML. So in short, the body of the AML should be spared. Basically, that is the main idea, to see that. Then only we can say that, because the rest of the part will be in the coaptation edges, but the body of the leaflet should be spared, and that is called the pliability. There is one scoring system that if you draw a line from in a systolic phase, when you draw a line from the annulus hinges to the coaptation and measure that distance, and measure the distance of the annulus to the concavity of the AML in the systolic phase, and the distance of the tip of the leaflet to the annulus, if it is less than half, I mean, if it is double, then the distance, and it is difficult to, I mean, I'll take one image to show it, sir. Should I take an image to show that?
Yes.
Yeah, I'll just take the image to show it. Any image, I'll just show the open it up. Anyway, I have to share it. I have stopped sharing it. Anyway, what I can say that you can see that you can measure the distance between the hinge of annulus to the tip of the annulus, and suppose it is a 5 millimeter. Now from that line, you measure the distance, the mid of that line, you measure the distance from there to leaflet, which is a concavity in the systolic. So this part should not be less than 1/4 of your previous measurement. So if you say A is the length of the base of the annulus to the tip of the annulus, and B is exactly perpendicular from that line to the concavity of the leaflet, that is called B. So B should not be less than 1/4 of the A. Rather, what in a nutshell I would say that when in the systolic phase, the body of the AML is going above the level of annulus, it is called the doming, and it is a pliable leaflet. That's it in the nutshell.
Thank you, Norman. I think we'll close it now. Thank you very much for joining us. I'm really